Okay, picture this. You're out hiking, maybe see a deer that's just off, stumbling, looking confused. Or maybe it's closer to home, your alpaca suddenly just can't get up. In those moments, understanding what could be going on, like trauma to the central nervous system, CNS, it becomes really critical. So today we're doing a deep dive into exactly that CNS trauma, but with a specific focus. We're looking at two really interesting and very different animal groups, Camelidae, so llamas and alpacas, and Cervidae deer, elk, moose. Our mission here is to sift through a lot of great information, pull out the key insights for you. Think of it like your shortcut to getting properly informed on, well, a pretty complex topic in veterinary and wildlife health. Because while the basic science, how a brain or spinal cord reacts to injury, is sort of universal. How it plays out, especially how we manage it in these specific groups, that reveals some really profound, sometimes surprising differences. Okay, let's unpack this.
Right. So when we talk about CNS, trauma, brain, spinal cord,
Yeah.
either one, there's this fundamental two-phase process happening. First, you've got the primary injury.
Yeah.
That's the immediate hit, the direct damage. It happens right at the moment of impact. And honestly,
Yeah.
that part is often irreversible. What's done is done, mechanically speaking. But then comes the secondary injury. And arguably, this is where the real clinical focus lies. It's this cascade, this sort of biochemical storm that unfolds over minutes, hours, even days after the initial trauma. And it's this secondary damage that we actually try to target therapeutically. That's our window of opportunity, really.
That's where the real battle begins then, isn't it? Trying to stop that cascade, especially with, say, a traumatic brain injury, a TBI. The primary injury might be a bruise, a tear, something obvious. But what's happening next?
Yeah.
Under the surface.
Exactly. After that initial impact, you get this domino effect, bleeding inside the skull or swelling, edema. And the skull, well, it's a rigid box, right? It doesn't expand. Precisely. So any extra volume from blood or swelling causes intracranial pressure, the ICP, to just skyrocket. This quickly starts to squeeze the blood vessels, reducing cerebral blood flow, CBF, and starving the brain of oxygen and glucose. And the brain is incredibly hungry. I mean, it's only about 2% of body weight,
Right.
but it hogs, 20% of the body's oxygen? And 25% of its glucose. Needs constant supply.
Wow.
So if that pressure keeps rising, the brain might try this kind of last-ditch effort, the Cushing's reflex. It signals the body to dramatically increase blood pressure, trying to force blood back into the brain against that high ICP.
A desperate measure.
Totally. And meanwhile, at the cellular level, it's chaos. You get excitotoxicity, brain cells literally getting overstimulated by stress signals. They release excess glutamate, calcium floods in, they basically burn themselves out. Plus, oxidative stress-free radicals damaging cell membranes. And inflammation kicks in, the blood-brain barrier breaks down. It's just this vicious cycle of ongoing cell death. It can continue for days, even weeks.
Okay, so that's the brain. What about the spinal cord, SCI? How do those primary injuries look, and is the secondary cascade different there?
Well, SCI also involves that direct mechanical damage. You can classify primary injuries in a few ways. You might have impact with persistent compression, like a bone fragment, or a disc pushing on the cord, or impact without ongoing compression, just a transient blow, or distraction where vertebrae get pulled apart. And then there's laceration or even transection, a physical cut through the cord. All of these immediately wreck neural tissue, the axonal tracts carrying signals, and the spinal vasculature.
Right, the immediate damage.
Exactly. And then, just like TBI, SCI triggers that secondary injury cascade. You get vascular disruption, ischemia, excitotoxicity, inflammation. Very similar mechanisms. But the spinal cord has a unique long-term issue. Glial scar formation.
Ah, the scar tissue.
Precisely. After the initial mess clears up a bit, specialized glial cells react by forming this dense scar around the injury site. And it's not just a physical block. It actively releases chemicals that inhibit nerve fibers, axons from regenerating. This glial scar is a major reason why permanent neurological deficits are so common after severe SCI. It actively prevents healing, in a way.
So wrapping this part up, what's the key takeaway for you, the listener? It's that understanding this two-phase process, the immediate primary hit, and then that creeping secondary damage is absolutely fundamental. It's the cornerstone of how we approach neurotrauma in, well, pretty much all species. Every intervention, from the ER to long-term care, is focused on limiting that secondary cascade, trying to save as much function as possible. Okay, now let's take that universal science and see how it plays out in our first specific group. Camelids, llamas, and alpacas. Their unique anatomy, their behavior, and especially how closely they live with humans. It really creates a different clinical picture for CNS trauma.
It absolutely does. What's maybe surprising is how often CNS trauma in camelids is iatrogenic or related to their captive environment. we see a significant number of injuries linked to improper handling or restraint.
Like during training or vet visits?
Exactly. Think about their long, very mobile necks. If a powerful llama panics and pulls hard against a halter or restraint, they can actually cause vertebral subluxation, basically shifting a vertebra out of alignment, or even worse injuries in their neck. We also see injuries from getting tangled in fences, gates, feeders, things in their environment, and pure trauma too, especially between intact males fighting.
Right.
Their neck anatomy just makes them vulnerable, long, flexible, but maybe not as heavily muscled for stabilization as, say, a horse.
So those neck injuries are a really big deal for them. You mentioned subluxation. Is that common, and where does it usually happen?
Yes, cervical vertebral luxation and subluxation are relatively common and well documented. It often occurs in the mid-cervical region. C3, C4, C4, C5, C5, C6 are common spots. But you can even see it right up at the base of the skull, the atlanto-occipital joint.
And how does it look? What signs do they show?
That's the tricky part. It can range wildly, from just a subtle head tilt or neck deviation to severe wobbliness, weakness in all four limbs, or even complete inability to stand, tetraplegia, and diagnosis. Often delayed because their thick fiber coat can completely mask swelling or any subtle deformity in the neck vertebrae. You might not see anything wrong from the outside initially. This brings us to, honestly, one of the biggest challenges in camelid neurology. It's the neurological diseases that perfectly mimic trauma.
Ah, the lookalikes.
Exactly. And the number one culprit, the most critical differential diagnosis you have to consider in North America, is meningeal worm, Paralophostrongylis tenuis.
Deer worm, right.
That's the one. White-tailed deer are the normal host. But llamas and alpacas are aberrant hosts, dead-end hosts. They accidentally ingest the larvae, usually on pasture. The worms then migrate erratically through their brain and spinal cord, causing inflammation and damage wherever they go. And the signs: asymmetric ataxia, like stumbling worse on one side, progressive weakness, head tilts, circling. It can look identical to a physical injury. You often can't tell the difference just by looking.
Wow, okay. That's a huge complication.
It is. And on top of P. tenuis, you also have to think about other things. Listeriosis, that's a bacterial infection. Viral encephalitis, things like EHV1, EE, West Nile virus, even inner ear infections causing balance issues, bacterial meningitis, or polioencephalomalacia. This is a brain disease caused by thiamine deficiency. All can present with neurological signs.
So this raises a really critical point. With all these potential causes looking so similar, why is getting the right diagnosis and getting it fast so vital in a camelid? What's at stake?
The stakes are incredibly high, because a misdiagnosis can lead to completely inappropriate, even harmful treatment. Take corticosteroids, for example.
Yeah.
A standard treatment to reduce inflammation in acute spinal trauma.
Right.
But if you give high-dose steroids to an animal that actually has meningeal worm or listeriosis or bacterial meningitis, you're suppressing their immune system. You could make the infection drastically worse, potentially fatal.
Oof. Okay.
Conversely, if it is a traumatic injury, like an unstable vertebral fracture that needs surgery, just treating for meningeal worm with dewormers isn't going to fix the physical compression on the spinal cord.
So you absolutely need to know what you're dealing with.
Absolutely. A rapid, accurate diagnostic workup is paramount for any camelid showing neurological signs. It's the most crucial step.
So how do you do that? What's the process?
Well, it starts with a really systematic neurological exam. You watch them move, observe their posture, check cranial nerves, test reflexes, assess their gait. But you have to remember, camelids can be quite stoic. They might hide subtle deficits. Then CSF analysis, cerebrospinal fluid, is often essential. We collect fluid from around the spinal cord or brain. If we see a high number of eosinophils, a specific type of white blood cell in that fluid, that's a huge red flag for P. tenuis, the meningeal worm.
Okay.
Other cell types point elsewhere. Lots of neutrophils might suggest bacterial meningitis. Mononuclear cells could mean listeriosis or a virus. And if the fluid is yellow or xanthochromic, that can indicate previous bleeding in the CNS.
So the CSF tap is key. What about imaging, seeing inside?
Right. If trauma is high on the list, imaging is critical. Standard x-rays, radiographs are usually the first step. Good for spotting obvious fractures or dislocations in the neck or skull.
Okay.
But for more complex bone injuries, maybe skull fractures near the ear, computed tomography, CT, gives much better bony detail. However, the gold standard for actually looking at the soft tissues, the brain, parenchyma itself, the spinal cord, detecting bruising without major bleeding, things like that, is magnetic resonance imaging, MRI.
MRI gives the best picture of the actual nerve tissue.
Exactly. It's invaluable for differentiating subtle trauma from other lesions.
So once you have a diagnosis, or at least a strong suspicion, what are the treatment options?
It really depends. For, say, A mild, stable, traumatic injury, conservative management might be enough. Strict stall rest, anti-inflammatory drugs like flunixin, migalumin, or meloxicam, maybe a single high dose of corticosteroids right at the beginning for severe acute inflammation, though that's used cautiously now.
Right, because of the infection risk?
Precisely. If meningeal worm is diagnosed or strongly suspected, the treatment is high-dose fenbendazole, an antiparasitic, usually for 5 days, often combined with NSAIDs to manage the inflammation caused by the dying worms. For unstable traumatic injuries, like a badly displaced vertebral fracture, surgical stabilization might be an option, things like laminectomy to decompress the cord or fusing vertebrae. But surgery carries significant risks, and the prognosis is often still guarded. And never forget supportive care. For any animal that's down, recumbent, you need intensive nursing, frequent repositioning to prevent pressure sores, assisted feeding and watering, fluid therapy. It's crucial.
And overall, what's the general outlook, the prognosis for camelids with serious CNS issues?
Generally speaking, for severe CNS trauma, the prognosis is guarded to poor. It really depends on the severity of the initial injury and the degree of secondary damage. Meningeal worm cases, sometimes they have a slightly better prognosis if the animal remains ambulatory, able to stand. But even then, residual neurological deficits are pretty common. Irreversible damage often occurs before treatment can stop the worms.
Right. It's a tough situation for them. Okay, let's switch gears now. Let's turn our focus to cervids deer, elk, moose. Their world is very different, wild or maybe semi-domesticated on farms, but that environment and their natural behaviors, they lead to different injury patterns and critically huge differences in how we manage them.
Absolutely. The etiology, the cause of CNS trauma in cervids, is often quite different, much more high-energy, violent trauma. Deer vehicle collisions, DVCs, that's the big one, especially for wild white-tailed deer.
Those numbers are staggering.
They really are. Estimates are around 1.5 million DVCs annually, just in the U.S. These are high-speed impacts, often causing devastating polytrauma, multiple severe injuries, including profound CNS damage, often immediately fatal or requiring euthanasia.
And besides cars,
Intraspecific aggression, fighting between males, especially during the rutting season.
headbutting, antler clashes.
Exactly. This commonly leads to head injuries, skull fractures, and it can also lead to a very specific nasty sequela called cranial abscessation syndrome, or CAS.
Right, CAS. You mentioned that primarily affects antlered males. Tell us more about how that develops.
Yeah, it's mostly seen in bucks or bulls.
Yeah.
What happens is bacteria, very often Truparella pyogenes, get introduced through wounds sustained during rutting. Maybe a broken antler tine, an injury to the velvet, or a puncture wound near the skull.
Okay.
The infection takes hold, spreads into the skull bone, causing osteomyelitis, and eventually penetrates into the cranial cavity, forming abscesses right on or in the brain.
Like pockets of infection inside the skull.
Precisely. And these abscesses act like growing tumors, essentially. They take up space, increase pressure, and directly damage brain tissue. The clinical signs, they directly reflect that pressure and damage. Ataxia, so wobbliness, circling, apparent blindness, sometimes a really striking loss of fear of humans, or even aggression.
And those signs could easily be mistaken for a direct brain injury from the fight itself, couldn't they?
Absolutely. Or they can look remarkably similar to other major neurological diseases in deer, particularly chronic wasting disease.
Ah, CWD. That brings us to the other major complication in cervids, these confounding diseases. Tell us about CWD.
Chronic wasting disease. It's a huge issue in cervid health, a prion disease, similar to mad cow disease in cattle or scrapie in sheep.
Prions aren't bacteria or viruses, right? They're misfolded proteins.
Exactly. Misfolded proteins that cause other proteins to misfold, leading to progressive, fatal neurodegeneration. It affects deer, elk, moose, reindeer. The really tricky thing about CWD is its long incubation period. Animals can be infected for months, even years, shedding prions and looking perfectly healthy.
Spreading it silently.
Right. Then eventually, clinical signs appear. The classic wasting, so progressive weight loss despite eating, behavioral changes, listlessness, repetitive movements, sometimes that lack of fear, and neurological signs like ataxia, head tremors, stumbling. Again, massive overlap with signs of TBI or CAS.
And you can't tell for sure just by looking.
Absolutely not. Definitive diagnosis of CWD requires post-mortem laboratory testing of specific brain or lymphoid tissues. There's no reliable live animal test for routine use yet, though research is ongoing.
Okay. So CWD is a massive confounder. What else?
Well, our old friend Paralophostrongylis tenuis, the meningeal worm, shows up again.
But differently than in camelids.
Yes. Remember, white-tailed deer are the normal, definitive host. They rarely show any clinical signs. The worm has co-evolved with them. But other cervids, moose, elk, caribou, even fallow deer sometimes are aberrant hosts, just like llamas and alpacas. So when they get infected, the worm migration causes severe neurological damage. Often looks like spinal cord injury, lameness, stiffness, paralysis. Especially devastating for moose populations in some areas where deer densities are high.
So the same worm, but different outcomes depending on the host species. Okay, this brings us to what seems like the most stark difference. The actual management challenges and, frankly, the welfare considerations for wild cervids. You hinted at it, but trying to capture and treat an injured wild deer, it sounds almost impossible sometimes. Why is it so difficult?
It's fundamentally challenging because of their innate biology as prey animals. Their flight response is incredibly strong. Cornering, chasing, restraining. It triggers an overwhelming physiological stress response and a desperate physical struggle.
Even if they're badly injured.
Oh, yeah. Adrenaline is powerful. An injured deer can still move surprisingly fast and forcefully. The struggle itself can easily worsen the original injury. Imagine a fractured leg becoming completely displaced. Or it can cause entirely new severe injuries. And attempting chemical capture, like tranquilizer darts, is also fraught with difficulty. The animal might run into danger traffic, water, dense brush before the drug takes effect. Dosages are hard to judge.
And this struggle, this intense stress, that leads directly to the biggest problem, right? Capture myopathy.
Precisely. Capture myopathy, CM. This is the single greatest obstacle and complication in attempting to handle or treat injured wild cervids. It's iatrogenic, meaning it's caused by our intervention. The extreme physical exertion and physiological stress of the capture process itself triggers it.
And it can be worse than the injury you were trying to treat.
Often, yes. The prognosis for established capture myopathy is frequently graver than for the initial trauma, assuming the trauma wasn't immediately catastrophic. What happens is the intense, prolonged muscle exertion, often under anaerobic conditions, leads to a massive buildup of lactic acid, severe metabolic acidosis. Muscle cells start to die rhabdomyolysis. They release myoglobin, which damages the kidneys, leading to acute kidney failure. They also release potassium, leading to hyperkalemia, which can cause fatal cardiac arrhythmias. It's a multi-system meltdown triggered by stress and exertion.
That sounds absolutely devastating. How does it actually look in an animal? What are the signs?
CM presents in a few different syndromes. There's capture shock, which is rapid collapse, ataxic myoglobinuric syndrome with stiffness and dark urine, ruptured muscle syndrome, or a delayed peracute form where they seem fine, then suddenly die hours later. Common signs you might see are muscle tremors, stiffness, difficulty moving, sometimes hyperthermia, dangerously high body temperature weakness, collapse, and that characteristic dark, reddish-brown urine from myoglobin.
And treatment.
Treatment for established CM is very difficult and rarely successful, especially in a field setting. Supportive care with fluids, potentially bicarbonate, temperature management, it's intensive and often unrewarding. So prevention is absolutely everything. Minimizing pursuit time is critical, ideally less than 2-3 minutes. Reducing sensory input blindfolding helps calm them. Choosing the least stressful capture method possible for the situation. Managing body temperature carefully.
This really highlights a profound management paradox, doesn't it? The very act of trying to intervene, trying to help an injured but still mobile wild cervid carries a very high risk of causing a condition that's often more rapidly fatal than the original problem.
It's a harsh biological reality. And it dictates much of the approach to injured wildlife. For a significant number of traumatic injuries in wild deer, particularly limb fractures or injuries where the animal is still mobile, non-intervention is often considered the most humane course. It avoids the extreme risk of CM and allows the animal's natural resilience and healing processes a chance, or allows nature to take its course if the injury is too severe. Euthanasia is, of course, the appropriate choice if the initial injury is clearly catastrophic and causing severe suffering.
Okay. So let's try to synthesize all this. We've talked about the universal pathophysiology, then camelids, then cervids. What are the core comparative takeaways? What really stands out when you put these two groups side by side?
Well, first, the etiology, the cause of the trauma, is often quite different. Camelids. We see a lot of lower velocity injuries often related to handling, restraint, their captive environment. Cervical subluxations are a classic example. Cervids, especially wild ones, dominated by high-velocity trauma from DVCs, or specific injuries like CAS, resulting from natural behaviors like rutting. Much more violent mechanisms, typically.
Okay, difference in cause. What else?
The confounding diseases. The mimics, they differ significantly in importance. For camelids, especially in North America, P. tenuis is the big one you absolutely have to rule out or confirm. For cervids, while P. tenuis affects aberrant hosts like moose and elk, the overarching concern, especially from a wildlife health and public perception standpoint, is chronic wasting disease, CWD.
Right. Different primary disease concerns.
And third, the nature of the iatrogenic, the risk from us intervening. For camelids, sometimes the handling itself can cause the primary CNS injury. For cervids, the major iatrogenic risk isn't causing the initial injury, but triggering fatal capture myopathy as a secondary complication during the attempt to manage an existing injury.
Those differences lead to fundamentally divergent clinical approaches, don't they?
Completely. For a sick camelid, it's individual patient veterinary medicine. You're aiming for a specific diagnosis for that animal. You use advanced diagnostics like CSF analysis, maybe MRI. You provide intensive, targeted treatment, maybe surgery.
For one animal-specific care.
Exactly. For wild cervids, the approach is generally driven by population health and animal welfare considerations at a broader level. The high risk of CM often makes non-intervention or euthanasia the most practical and humane options for mobile injured animals. Diagnostics are often post-mortem, focused on surveillance for diseases like CWD. Intensive treatment is usually reserved for valuable farm animals or situations where capture stress can be exceptionally well managed.
So, looking ahead, where does research need to go? What are the critical gaps for each group?
Good question. For camelids, we could definitely use more robust data on long-term outcomes after surgical interventions for spinal injuries. A deeper understanding of P. tenuis pathophysiology might open doors for better treatments, maybe immunomodulatory therapies alongside the antiparasitics, and more pharmacokinetic data on pain medications in camelids would be helpful for optimizing analgesia.
Okay, so better surgery data, better worm understanding, better pain management for camelids. What about cervids?
For cervids, a top priority, undoubtedly, is the development of sensitive, specific, and practical live animal tests for CWD. That would be a game changer for surveillance and management.
Being able to test a live deer reliably.
Huge. Also, more research into pharmacological agents or handling techniques that could potentially mitigate the risk or severity of capture myopathy would be incredibly valuable, though it's a tough nut to crack physiologically. And of course, continued efforts on DVC mitigation. Things like wildlife crossings, roadside fencing, driver awareness programs remain crucial for reducing that primary source of trauma.
It really underscores, doesn't it, the complexities and the continuous ethical tensions we navigate in our interactions with animals, whether they're companions, livestock, or wildlife. That interface between veterinary medicine and wildlife conservation is full of these challenges. So hopefully, after this deep dive, you have a much clearer picture. You understand the universal ways the brain and spinal cord react to trauma, but also the drastically different realities, how injuries happen, what other diseases complicate things, and how we approach management in our domestic camelids versus wild cervid populations. It's quite a contrast. And maybe a final thought to leave you with. As our human footprint continues to expand, how does that constantly reshape the challenges we face and the responsibilities we hold towards animal health and welfare across all these different contexts, managed, wild, and everything in between?